Evaluation and management of early breast cancer. Early breast cancer refers to localized disease confined to the breast or the breast and regional lymph nodes. Timely evaluation and treatment are critical to improving survival rates and maintaining quality of life. Here's a detailed overview. Evaluation of early breast cancer. 1. History and clinical examination. Patient history. Assess risk factors, family history, genetic predisposition, hormone replacement therapy, symptoms, breast lump, nipple discharge or skin changes, and comorbidities. Physical examination. Evaluate the breast and regional lymph nodes for abnormalities. 2. Imaging studies. Mammography, the cornerstone for diagnosis, detects microcalcifications and mass lesions. Ultrasound, useful for characterizing masses, especially in younger women with dense breasts. MRI, recommended for high-risk patients or in cases of inconclusive findings. 3. Tissue diagnosis. Core needle biopsy, standard for histopathological diagnosis and receptor testing, ER, PR, HER2. Fine needle aspiration cytology, ENaC, occasionally used for palpable lesions but less detailed than core biopsy. Sentinel lymph node biopsy, SLNB, to evaluate regional lymph node involvement. 4. Staging. Pathological staging, based on tumor size, T, lymph node involvement, N, and absence of distant metastases, NRO. Imaging for staging. CT scan, bone scan, or PET-CT may be required for symptoms suggestive of metastases. 5. Biomarker testing. Assess for hormone receptor status, ER and PR, and HER2 overexpression. Ki67 index may be used to evaluate proliferation rates and guide therapy. Management of early breast cancer. Chart 1. Surgical treatment. Breast conserving surgery, BCS, involves lumpectomy with clear margins, followed by radiation therapy. Mastectomy may be necessary for large tumors relative to breast size, multicentric disease, or patient preference. Axillary management. Sentinel lymph node biopsy, SLNB, for clinically node-negative disease. Axillary lymph node dissection, ALND, if SLNB is positive or in cases of clinically node-positive disease. 2. Radiation therapy. Indications: post-BCS, post-mastectomy with high-risk features, e.g., large tumor size, multiple positive nodes. Techniques: whole breast irradiation, partial breast irradiation, or regional nodal irradiation. HA3. Systemic therapy. Hormonal therapy, indicated for ER/PR positive tumors. Options include tamoxifen or aromatase inhibitors, AIs, depending on menopausal status. Chemotherapy, recommended for triple-negative, HER2-positive BRCA or high-risk hormone receptor-positive disease. Regimens include anthracycline and taxane-based combinations. Targeted therapy, HER2-positive tumors, trastuzumab, pertuzumab. Neoadjuvant therapy, indicated for locally advanced disease to downstage tumors and improve surgical outcomes. Genetic counseling and testing. Recommended for patients with a strong family history or young age at diagnosis to identify BRCA1, BRCA2, or other genetic mutations. Results may guide treatment decisions, including prophylactic surgeries or targeted therapies like PARP inhibitors. 5. Follow-up and survivorship care. Regular follow-ups with physical exams and mammograms. Management of therapy side effects, such as lymphedema or bone health. Psychosocial support and addressing quality of life issues. Emerging therapies and advances. Immunotherapy, PD-1, PD-L1 inhibitors are being explored for triple-negative breast cancer. Genomic assays, Oncotype DX, MammaPrint, or similar tests to guide adjuvant therapy decisions. De-escalation approaches. For low-risk patients, minimizing treatment intensity without compromising outcomes. Prognosis. Early detection and personalized treatment approaches have significantly improved outcomes. 5-year survival rates for early breast cancer exceed 90% when managed effectively. By integrating advances in imaging, surgery, systemic therapies, and patient-centered care, the management of early breast cancer continues to evolve, offering better outcomes and quality of life for patients.